Welcome, everybody. We're going to give everybody just a minute to get into the room and get settled. We are very happy that you're here to join us for our SimiTree webinar today. As I said, we're going to give everybody just a minute to get into the room, and then we'll go ahead and get started with the webinar. I see a bunch of you still jumping in and getting joined, so I want to make sure everybody's audio is up and working. If you need anything or run into any issues, please don't hesitate to use the chat feature. As we're going through the presentation today, please put your questions in the question and answer field. We'll be able to get to your questions either at the end of the presentation as our goal, but if we run out of time, we'll certainly circle back around to you and make sure you get your questions answered. If you do have any questions, go ahead and put them in the chat. I'll be happy to answer them. I will be posting the handout in the chat after we get started. It's a web link that'll take you out to the handout. Looks like we have most everybody into the room now. So I'm going to go ahead and get us started. My name is Missy Gilliland. I'm the Director of Learning and Development here at SimiTree. We're very excited to have you join us today for our webinar. If you have any questions, please don't hesitate to put them into the chat or into the question and answer field. We will be sending out a follow-up after this presentation that will include a link to the handout and a link to the recording of the presentation for future reference. With that, I'm going to go ahead and turn it over to Kim and Lynn to introduce themselves and get the webinar started. So, Kim, if you want to take it.
Sure. Thank you, Missy. Sorry, want to make sure I get to where I have to go. Hello, everyone. My name is Kim Skian, and I am a managing director for SimiTree. I oversee our compliance and regulatory team and support our clinical mergers and acquisitions team. I'm very pleased to be presenting today's webinar along with Lynn Smith, who is an RN and senior manager on our compliance and regulatory team. Lynn comes to us from her recent experience as a hospice and home health surveyor and has a wealth of knowledge and experience to share. Lynn and I will outline key changes in the CMS State Operations Manual Appendix M, primarily focusing on changes in the survey process and what hospice providers can expect with upcoming surveys. And importantly, we will also discuss key strategies that hospices can utilize to implement a proactive, agency-wide, ongoing survey readiness program that incorporates these additional surveyor probes and focus areas. We do welcome questions, as Missy mentioned, during the presentation. And if we're unable to respond during the webinar, we will provide follow-up to attendees. And as always, you may contact our SimiTree compliance and regulatory team at any time following this presentation as you begin to implement your updated survey readiness processes. And with that, we'll get started. It's important to understand the background of these changes in order to inform your agency processes for survey readiness and regulatory compliance. This often helps staff understand the reason behind your hospice's focus on regulatory compliance and any associated documentation and process changes and monitoring efforts. I am honored to have been working with industry leaders such as NHPCO, NAC, and state associations over the past several years, addressing these statutory and regulatory changes and providing survey readiness and follow-up resources, guidance, and support for hospice providers. By now, most providers are familiar with these two Office of Inspector General reports, which were published in July of 2019. Which provided the impetus for these survey changes and enforcement remedies. Some of the common deficiencies from 2012 through 2016, which were reported in these reports, are still the most common today. And they include standards and conditions around care planning, as well as patient assessments. So it's important that we continue to make these areas a focus of our survey readiness efforts. Partially in response to those reports, the Hospice Program Integrity Act, or Hospice Act, was enacted on December 27th, 2020. The overall purpose was to improve the consistency of survey results and also reduce discrepancies between the state and accrediting organizational survey agencies. The provisions included surveyor education and reporting, including conflict of interest reporting, the requirement for accrediting organizations to submit survey findings to CMS, intermediate sanctions and enforcement remedies, the development of a special focus program, as well as a quality withhold increase, which included an increase from 2% to 4% in the reduction of the payment rate for hospices that do not meet the requirements for hospice quality for the hospice quality reporting program. Most of the provisions were in effect or enacted between 10/21 and 10/22 or October of 2022, with the exception of the special focus program, which will be finalized in future rulemaking. Many were finalized in the 2022 home health final rule, and the SOM survey changes we are presenting today have also been made to reflect these requirements. So in November of 2021, the fiscal year 2022 home health final rule included CMS regulatory changes as required by the Hospice Act. So you can see where we're connecting the dots from first industry concern to statutory requirement to regulation and now to implementation. And these changes included the survey changes found in Appendix M of the State Operations Manual, as well as a description of Subpart N enforcement remedies, which will be published in the Medicare Program Integrity Manual at a future date. The enforcement remedies include temporary management, payment suspension, a directed plan of correction or in-service training, civil monetary penalties, and/or termination. It's important to note that even though the Program Integrity Manual has not been updated, enforcement remedies have the possibility of being considered or implemented as of the 10/1/2022 date, although it remains to be seen as we're waiting for that publication. Condition level deficiencies, as well as a history of frequent or repeated condition level deficiencies, may lead to enforcement actions or sanctions. And for this reason, your hospice must be able to demonstrate compliance with the COPs and standards, as well as compliance with your own policies and procedures. Ongoing survey readiness is a key factor in mitigating negative survey findings and in helping all staff and managers in understanding their role in regulatory compliance. The State Operations Manual Appendix M is where you'll find not only the COPs, standards, and interpretive guidelines, but also the survey tests which guide surveyors in the survey process and include probes for interview and document review that may be utilized by surveyors in assessing the hospice's compliance. The changes to the SOM were published on January 27th, 2023, and are effective immediately, although survey agencies have 30 days from that date to provide surveyor training. The CMS surveyor training may be found online and is accessible to the public and includes these updates. While there are no changes to the conditions of participation or the standards themselves, the more focused and detailed surveyor tasks and guidance will likely impact all hospice surveys and have implications on the potential for an increase in condition level deficiencies and subsequently possible survey enforcement remedies. The focus on these COPs, these four that are listed as the core COPs, are consistent with where we have seen the majority of condition level findings in the past, specifically around patient rights, the care planning, and also comprehensive assessment. There are 23 COPs in total. There are these four core, and the 19 other COPs are associated with these core COPs. It's also important to understand that the COPs are weighted equally. The core COPs help to focus the surveyors on areas to identify potential quality of care issues, but the hospice must be able to demonstrate compliance with all of the COPs. Overarching these requirements is a quality assessment and performance improvement program that builds on the philosophy that a provider's own quality management system or QAPI system is key to improving patient care performance. The objective is to achieve a balanced regulatory approach by ensuring that a hospice furnishes care that meets essential health and quality standards, while ensuring that it monitors and improves its own performance. So your QAPI program and the demonstration of implementation of your QAPI program in response to your own identified issues is key and is a key area for survey. The protocol phases are sequential. Phase 1 findings regarding direct care services can inform phase 2 in terms of pointing to potentially systemic issues and deficiencies. However, as previously noted, all COPs and standards are weighted equally. So again, you do want to ensure that your organization can demonstrate compliance with all COPs. The guidance to surveyors in each of these standards or each of these tasks is identified on this slide is found in the State Operations Manual under the Survey Tasks Overview. It is much more comprehensive than has been in the past. The procedures and probes used by surveyors to assess compliance and quality used to be under the Interpretive Guidelines, but they're now part of the survey tasks, and the probes are much more detailed and targeted. The pre-survey tasks in task 1, in task 1, the surveyor is reviewing internal and external resources to assess the current characteristics and services of the hospice, including Care Compare and other publicly available reports, as well as your own marketing, meaning your website and social media and other, other marketing materials to ensure or to validate that the services that the hospice is saying that they indicating that they are providing and the locations of service under that provider are consistent with what CMS has in terms of records and requirements and with the agency's procedures and what they are communicating to patients and families and to the public. The entrance conference used to be called the entrance interview, and it's more discussing the logistics of the survey process, as well as working with hospice leadership or key leadership, but no longer is an interview, if you will, specifically related to the organizational structure and processes. I will say here, though, that the administrator and leadership of the organization, as well as managers and staff, will still need to be able to demonstrate compliance with the regulations or demonstrate how they comply with regulations, specifically around organization and administration. The new task for sample selection is a separate task to more clearly define sample selection protocol for clinical records, and Lynn will speak further about this. We also have information gathering, which is task 4, which provides a more specific investigative protocol based on the core requirements and quality of care concept. Surveyors gather information using a set of procedures, which are common across all provider types and include observations, interviews, record and documentation review as well. And as a reminder, you will also be surveyed for compliance with your own agency policies. So ensuring your policies and procedures are in compliance with regulation, are reflective of your agency operations, and that staff are aware of your agency policies is a key survey readiness recommendation. It is incumbent on your agency to be able to demonstrate how your policies, procedures, and daily processes and practices meet the COPs and standards. The remaining tasks, 5, 6, and 7, I apologize, have not changed in terms of the overall content, but you do want to ensure that as part of your survey readiness processes, you do review these tasks and that you are aware of how the surveyor could potentially cite condition versus standard level deficiencies, and also what your role is in terms of the exit conference and post-survey activities. And with this, I'm going to turn the presentation over to Lynn to talk about some of the core COPs and associated COPs and key survey readiness strategies. Lynn?
Okay, thank you, Kim. Good afternoon, everyone. I'm going to discuss starting with task 3, but we're going to go through task 3 and task 4. And where you're going to see is really how this is going to change the survey process is it's going to be very specific what the surveyors are going to be looking for. So when you get a chance, make sure to really go through that. The Appendix M, that goes over all of this, because it really outlines exactly what kind of the questions and everything that they're going to be asking. So task 3 talks about the sampling strategies for record reviews. It was always in the past, the records reviewed were based on the unduplicated census, but also I think they wanted to expand out to make sure that they're covering whether for bereavement, as well as some of the people that have been, discharges, revocations, all of that. So it's much more specific. You can see that they increased the number of records to ensure a broader range of hospice activities. Like I said, live discharges, bereavement follow through, care for patients needing higher levels of care, and then from all the locations wherever the hospice operates, if you have like multiple settings. So that it ensures that they're able to see more, that's a broader range of what's going on within the hospice. Next slide. So next slide, Kim.
I apologize. I had a little delay. Is this
Yeah, that's
correct?
okay. That's okay.
Technical
So
difficulty.
you can see, like for survey readiness strategies, what do you need to be thinking about now that they have more specifics related to record reviews? So what they're going to be looking at, your number of unduplicated admissions, obviously for the recent 12-month period. They're just going to be looking for that number, because that determines how many records that they need to review. Then they're going to confirm if there's any type of multiple locations, because if you have multiple locations within your hospice, they will want to do record reviews, home visits in the different areas as well. So what you need to have ready once you know the surveyor is coming is some of these lists. You're going to see your active patients from all payer sources, from all your locations. You want to include the patient name, date of admission, terminal diagnosis, location of the patient, and core services. So you want to make sure that you're printing what they need so they can determine what records they want to review. Also, they may ask if you have a list of any patients that are in GIP level of care, because if it's possible that you do, they would want to maybe do a visit there or review that record. Also, maybe they'll ask patients who have received respite care in the past year, and patients who have had continuous care in the past year. So this is going to give them some indications of, again, records that they can review. Also, they're going to look for patients who have revoked the hospice benefit. So we're looking at live discharges. Plus, they're going to look at not only patients that have revoked the hospice benefit, but maybe those that have the long lengths of stay that maybe have exhausted their hospice days, not so much their hospice days, but their diagnosis has gone way past the 6 months that they originally thought. So they're going to also look at those. And deceased patients in the past 12 months, and of those, who's receiving bereavement services. So surveyors are going to look more closely at these records they're choosing to review, whereas a lot of times surveyors will say, okay, I need eight so many active records, so many discharge records, whereas you're going to see the next slide where it's very specific, where closed records, live discharges, you've got closed records, bereavement records, record reviews with no home visits, record reviews with home visits, and you're going to see where your minimum sample has increased. You've gone from 14, 19, 23, 27, and you'll notice for home visits, usually for a lot of the census, it was 3. But now you're going to see 3, 4, and up to 6 if the agency is large. And so this gives the surveyor a much clearer picture as to what kind of records that they're going to be looking at and how many. Okay. So what I wanted as a reminder, this is the list of the phase 1 core COPs. So what I'm going to do is we're going to look at some of these COPs and then also look at some key associated COPs, the conditions of participation, that's really going to be something you want to look at during the survey process. So here are the phase 1 associated quality of care COPs, and you're going to see where it has infection control, home health aide, medical director. We're going to cover a few of those that are maybe had a few changes, or more so where there's much more specific in as far as the questioning, interviewing, and things like that related to the survey process. So the survey process that can the condition of participation, patient rights, it's very lengthy as far as what they want the surveyor to really look for. So this is the process where they're going to look for compliance in regards to the patient rights, not just, have they been given their the appropriate paperwork, but also they may go on to say, the surveyor may ask staff about filing complaints if they know the process and policy related to this, as well as who handles complaints and follow up within the agency. So that might be something they're going to ask staff about related to that. Big push now with these with the new survey process is patient rights, and then complaints, making sure that everyone is aware of how the complaint process works, who's responsible for it, and it's also important that the patients and families know that. So how are they going to do this? How would the surveyor do this? So what they're going to do during home visits, a big thing for patient rights is the admission packet or admission binder. They will go through that very extensively to make sure that all the required information is in there related to patient rights, related to HIPAA, related to advanced directives, all the things you're going to see listed that they're going to be looking at, those need to be in the home. So it's very important to make sure that the patient's families know where their admission packet is, their binder is, so you're able to, refer to that. You should be utilizing, the staff should be utilizing that at every visit, because oftentimes the surveyor will go in and the family has no idea where that admission packet is, and it's something that they're going to want to review. So the surveyor will interview the patient and family to determine were they informed of their rights? Were they instructed on who to call for complaints? Is the care meeting their needs? Did the agency provide patient rights in a language and a manner they understand? Oftentimes, you may be seeing people of different cultures. So how are you determining if they understand patient rights? Do you want to document that as a staff member to say that the daughter is always at the visit who would interpret for the patient, because that's something they're definitely going to be looking at. And were they informed of scope of services, their advanced directives, and do they understand that they have rights? A big push right now is pain management. Did the nurse go over pain management and that they're entitled to have good pain management? The other thing that they're looking closely at is, did they choose an attending physician, and is that documented somewhere? If they turned it over to the hospice medical director, or if they have an attending physician that wants to participate, it needs to be documented somewhere. Usually, I think most agencies are putting it on their consent, but you need to be very specific with that. And oftentimes some other questions, they'll ask how the admission process go. Did they go over everything, explain everything? Do you know how to get in contact with the agency? So a lot can happen related to patient rights during a home visit is when you're going to see a lot of that. But also with patient rights, you also want to make sure somewhere in your documentation, you're documenting also that you have instructed the patient, the family, whomever, that needs to be somewhere in the documentation of the record itself as well. Okay. Phase one, again, one of the core COPs, and this is obviously a very, it's a big area for survey review. Between this and plan of care, of course, is also a very a big area for survey review. So what this is it's the initial and comprehensive assessment of the patients. So it starts out with obviously we went over with the extensive record reviews, both active and closed records. There's much more, they're more specific now of how many records you need to get, active versus closed records, how many you need to do for based on your unduplicated census. So the clinical record is the evidence, the enduring evidence of care for patients and family. A review of the record assures the surveyor that the hospice provides services in compliance with the plan of care and the COPs. So the surveyor is going to be looking at quality of care, and a big one that they're going to be looking at is coordination of care and family-centered plan of care. That is big now. You can see it's very outlined in the new processes. So the other thing, they also are looking hard at individualized goals of care that are measurable and time framed. And based on that, they're looking for the documentation of progress towards goals. Very, very much so. The plans of care, need to be goal oriented so that you can document progress towards the goals. And of course, this is all going to be determined based on your comprehensive assessment. So the other thing to look at when you're looking at this is the timeliness of the referral process to the admission process. They want, they within that, you have to have that full comprehensive assessment within the required 5-day period. Some agencies are doing a 2-step admission process where they go and do maybe an initial assessment, and that should be completed within 48 hours of the referral, unless there's documentation against that. But then within the 5 days, they need the full comprehensive assessment has to be completed. So something to just be aware of. You want to make sure that you're getting the comprehensive assessment fully completed within that 5-day period if you're doing that 2-day type admission process. The surveyor will confirm that the comprehensive assessment is updated by the hospice IDG in collaboration with the attending physician. This is one that a lot of times a surveyor doesn't see that communication and collaboration with the patient's attending physician if they are involved in that within that hospice patient. So the other thing that to think about is also a lot of agencies use LPNs, and they are obviously a wonderful asset to the hospice program, but the RN drives the plan of care. She is the one that needs to do that comprehensive assessment at least every 15 days in prior to like IDG. Years ago in some different states, the LPN was visiting and they were just doing a supervisory visit at the end of the month. And Medicare determined you cannot do that. The RN must do a full comprehensive assessment at least, with every 14 to 15 days. So just as far as home visits, you want to verify that the comprehensive assessment and plan of care were completed. This is what the surveyor will do, and she's going to review medications, which of course we all know is always a struggle. That's going to include all prescriptions, over-the-counter meds, the herbal medications, and they'll compare to the agency's medication profile, this is all part of the comprehensive assessment. And then again, you're going to, during the survey, the objective would be obviously to interview patients and families as well about, the assessment, what's going on with the patient, and were they involved with identifying the goals of care. So, and then the surveyor is going to look at some of the goals and look at the patient during the visits, and then once reviewing the records doesn't match is something they're going to look at. And the last thing that just to really look into, they're really concentrating now on bereavement. It's receiving extra attention due to experiences with some hospices not having that defined bereavement group program with services provided, and they don't have a program that's customized to meet the patient needs. So the important thing about the bereavement, you want to make sure that that initial bereavement assessment is done, is complete and timely at the time of admission. It should be done within those 5 days of for the comprehensive assessment, and it also, all the information that's gathered must be incorporated in the hospice plan of care and considered in the bereavement plan of care going forward. The surveyor would going to review the bereavement program. Most of the time they will sit down with the actual bereavement coordinator and go through the program to make sure that they're providing care for up to 13 months. They're going to be looking more at the last few days before death, post-death bereavement, and counseling services. They're also going to make sure that does the bereavement plan of care contain the type and frequency of services offered? Is it is the bereavement plan of care individualized? The bereavement plan of care also needs to have goals. What are the goals that the bereaved person has following the death of their loved one? And then the survey will also look at if the hospice evaluates the outcomes and effectiveness of the bereavement services provided. This is part of QAPI. And with QAPI, you have to make sure that you are mentioning the bereavement component of your program at the QAPI meetings. And then again, when we talked about the live discharges, the surveyor may look at beneficiary-driven live discharge. What that means, the patient revokes the hospice benefit, maybe moves out of the area or transfers, and then agency-driven live discharges. This would be someone that's no longer terminally ill or discharged for cause, that maybe there was behavior issues, different things like that, and that they were uncooperative to the extent that delivery of care could not be completed. So there's just a couple different things to look at for discharges to get those records. Okay. So just kind of honing in on some survey readiness strategies. This is kind of basic, but it's something to always really take a look at. What for home visits? The surveyor is going to look at your bag technique, your infection control, hand hygiene, trunk supplies. That's something that people forget, that they actually will look at your trunk. Do you have a dirty section? Do you have a clean section? Again, we talked about medications, the patient family rights and communication. Again, that's going to be looking at, the admission packets, interviewing the patient's families. Interdisciplinary group and care coordination is, like I was saying, does the patient match what the record looks like? Is it are we looking at the same things? And again, looking at admission paperwork. Do you have an emergency plan for the patient? And then skilled nursing facility and assisted living coordination. That is a very big area that we're going to cover a little later, but it's definitely something that they want looked at more closely, because obviously sometimes you're not seeing the communication coordination of care when patients are in the SNF. And then some other additional things that they'll look at during the home visits is, your provision of the drugs, the treatment services, DME, and another thing that they're going to be looking at, especially now with the waivers coming down, is volunteer utilization. Okay. So this again is another core COPs, the coordination of participation, interdisciplinary group, care planning, and coordination of services. Obviously, this is also a big area where we're looking at the IDG, the IDT, however you all call that. It's basically a continuous feedback loop between the needs identified in the comprehensive assessment and an updated individualized plan of care. The nurse, who is a member of the IDG, monitors the effectiveness of the plan of care and serves as the liaison between the patient and the IDG. So the one thing that may end up happening, Kim, and you might want to interject in this, is they really want in the new process to an IDG meeting. So are you saying that maybe they're going to have to actually schedule one if it's not on for that week? Or have you heard anything related to that? I wasn't sure about that.
No, my understanding is that it is the same as as previous, which is that the surveyor will join an IDG, at least one, if they are scheduled during the time that the surveyor is on site.
Okay. I just wanted to, I wasn't sure. I've been hearing a little bit of everything related to that, but very specific questions that the surveyor is going to be looking at. Are the core services present? Are other hospice staff members involved in the patient's care participating? Are they all participating? Are family and caregivers encouraged to attend? I don't see that very often, but you know, you can, if there are some issues with the patient, it's probably, you know, it's actually would be something that you could do. Are the goals of care being reviewed and revised as needed? Is the plan of care being reviewed and revised as needed? How about are documented visits being addressed? And the surveyor will also assess for evidence of coordination of care and communication with IDG, patient family, and non-hospice providers, say your attending physicians, pharmacies, and then the communication again with your skilled nursing facilities.
And Lynn, I would just add here that even though an IDG may not be scheduled during the survey, the surveyor will look for evidence of IDG coordination and communication, again, through staff interviews, as well as documentation review, as you've laid out here. So they will look for that the evidence of the IDG communication, not just at the start of care or on the required every 15 days, or every 2 weeks that a hospice may have an IDG, but during the course of care, based on the patient's changes in status.
Okay, so next slide. So some survey readiness strategies based on, this would be for your IDG, IDT meetings, care planning, coordination of services. So you're going to review the IDG plan of care at each visit to ensure services are being provided per the plan of care. So that's going to help keep things updated. Ensure that the IDG plan of care updates include the frequency of each service provided. Ensure that coordination and communication between disciplines are documented with each visit by all disciplines. And documentation of patients or representatives' level of understanding, involvement, and agreement with the plan of care should also appear in the clinical record. So as a surveyor, she's going to be looking, he or she would be looking at, you know, they're going to be looking closely at your IDG, oh my goodness, I'm getting ahead of myself, IDG or IDT documentation. So they're going to be looking at, if there's no measurable goals and outcomes in the original plan of care, then it's going to be difficult to document progress towards those goals. Oftentimes, maybe the nurse documents the IDG notes when actually all disciplines need to be part of that IDG documentation. That, you know, whoever's in that home, even if they're not in the home, say the spiritual counselor is not in the home, they should still actually make a documentation in the IDG note to say, you know, that they are not, you know, that the patient had declined services but available if needed, something like that. So everyone needs to participate in the documentation piece, because you can sometimes see when a surveyor will look at sit in the IDG meeting, then look at the documentation and not seeing all the wonderful things that are being discussed. It has to be, you want to make sure that you're documenting all that. So another thing that mistakes you can see sometimes with the IDG documentation, cutting and pasting, they will cut and paste the last few visits, and there's your IDG documentation. That it's not meeting the actual goals of what you're trying to do with the IDG meeting. Just an example of something, it's PIG. I know it's not the prettiest word, but how to document on your IDG would be problems. What kind of problems does the patient have? The interventions that you're currently doing for those problems, and what are the goals and outcomes? So, and then on your briefly using that, basically what has happened the past 2 weeks, and then progress towards the goals and what is the plan for the next 2 weeks. So it's just an example of a way to maybe document on the IDG note, but that's a great place where you're going to be able to see goals, progress towards the goals for the patients. But also it's very important in routine notes and in the clinical records to document progress towards goals. And important to note again, what I mentioned before, that the patient family is understanding of the plan of care, is involved and agree with it. Okay. One of the associated quality of care COPs that I want to mention was home health aid. We know that this is oftentimes scored during a survey. So there's no significant changes related to the actual service, but just some things to consider when you're getting ready, when you're getting ready for a survey is a big area that's scored when the home health aid's not following the plan of care. And and oftentimes poor communication, where the aide may identify something, writes it on their note, but then there's no communication to the nurse. A lot of times they'll say, well, we text them. Well, it all has to be documented. If it's not documented, it wasn't done. The other thing is to make sure on the hospice aid plan of care, everything is included. If that patient has a G-tube, a PICC line, oxygen, it needs to be included on that home health aid plan of care. Also with the oxygen, if it's continuous, can it be removed for bathing or not? So basically anything that's abnormal for that patient, that's different, that it needs to be on the home health aid plan of care, so they're aware of it. If they have dressings and they go in and they didn't know the patient had a wound and there's no dressings on, then this way they know that the patient has a wound, the dressing's off, the nurse is going to have to come in there and redo the dressing. So it's just very important that you individualize those home health aid plans of care and expand out on those, so that the aide gets a full picture of the patient. And then your supervisory visits, of course, they every 14 days they need to be supervised. And just something to think about, if the aide is not following the plan of care and the nurse is supervising every 14 days and checks off that the aide is following the plan of care, sometimes then you can be cited twice for the aide not following the plan of care, and that there's lack of communication from the nurse standpoint, that that the supervisory visit is not effective because the aide was not following the plan of care. Just something to think about. And then the other thing, annual supervisory visits, that's going to be more in your personnel records, where they have to make sure that they are do a full competency check off yearly. Okay, the next one, I'm going to let Kim take this one. Give me time to breathe, because I'm talking about a minute. And she's going to discuss a little bit about the hospice medical director. There have been some changes and revisions for that.
Thank you. Thanks, Lynn, and great job. And we're moving along. We're making great progress in the presentation. And I really thank Lynn for the information and true real time guidance and real life guidance that really is helpful for providers. Regarding the hospice medical director and this COP, the COP and the standards have not changed. However, we do know that it has been an increasing focus over the past several years, in some cases, regarding the hospice medical director, the physician designee, and the role of these roles, as well as the roles of hospice physicians and other practitioners. CMS did in the state operations manual has implemented or published Table 1, the medical director responsibilities compared to all hospice physicians and practitioners, PAs, and I'll go over that. I'll show that in just one moment. But a couple of really important points regarding the medical director. The identity of the medical director will be verified through interview and documentation by the surveyor, and also the identity of the individual designated to serve in this capacity in his or her absence. It is important to remember that there is only one medical director per provider. So per your provider number, even if you have multiple I'm going to call them branches, but alternate locations or branches under that provider number, and hospice physicians are leading the IDG for a particular branch, the medical director, there's still one medical director for the organization. And oftentimes when we are conducting mock surveys, we will ask a field clinician from a branch location who is the medical director, and there are times when they will indicate or they will name the physician who is the hospice physician in that local branch. So it's really important that everyone understands who the medical director is and who the physician designee is. In addition, just a reminder that practitioners such as nurse practitioners and PAs cannot complete hospice certifications of terminal illness. If you have contracts for your physicians, meaning your medical director, physician designee, or physicians, you want to make sure that those contracts are in place and that they meet the COPs and standards around contracted services. You also want to ensure that your personnel files are current and complete for all of your employed, contracted, or volunteer physicians or practitioners. So in the case of physicians, if they're contracted, or the medical director, if he or she is employed, contracted, or volunteer. You still have to include all of the requirements per your agency policies related to background checks, health information, and in-service requirements. We often find this information lacking when we look at specifically contracted physicians or the medical director, making sure that those records are complete. It's again, the medical director or designee may be interviewed during the survey and or during IDG. And you also want to make sure that your hospice medical director can provide sufficient time to adequately oversee the medical component of the hospice. And this is the tables, just so that you are aware. And this table outlines in the tasks, again, in the state operations manual, more clearly outlines the roles of all of the physicians and non-physician practitioners with hospice. Just make sure there are no changes to the standards, but in the tasks, there are a couple of notable items that I think will be continued to be reviewed and evaluated, I think certainly by the national associations and continued conversation with CMS. This includes the statement in the task instructions or probes, evidence that the medical director is the only person who admits an individual to the hospice benefit in consultation with the individual's primary and or attending physician, and also confirmation that confirming that discharge orders are written by the medical director. So making sure that your hospice policies and practices are consistent with the standards and how you meet the standards with the medical director and or the designee is going to be key. With that, I'll turn it back to Lynn for the rest of the program. You're on mute, Lynn.
Of course, you knew that had to happen at least once. Just want to touch base. I won't spend a lot of time on this because a lot don't provide the inpatient care directly, but it's just there's 13 documented elements now that surveyors will be looking at. Prior to this, it wasn't as specific, and you'll see the next slide. You'll be able to review that. Within the changes, there's specific areas to concentrate during the tour, interviews, and record reviews. Surveyors will interview staff and patients' families, and they're going to want to observe some care being provided. The surveyor is going to spend a few hours at the facility. Will review processes like pharmacy, personnel files from the IPU, and they're going to review documentation because GIP has just been looked at so closely across the board. And another thing that is mentioned to think about is they're looking at restraints, seclusions. That has been big on the radar through any type of survey process. So Kim, the next slide. So this is just for your information. These are the 13 tasks that they've outlined that they're going to utilize for the inpatient unit. So, and just something to think about, this surveyor, if you're using like an accrediting body, a lot of times those nurses will do the facility tour, they'll do the life safety tour, as well as the actual survey of the unit itself and the staff and things. If you're just getting surveyed from the Department of Health, oftentimes they have their own life safety surveyor, and then they'll have a nurse surveyor come in to look at the other aspects of the IPU.
And Lynn, I just want to add to that. We recently, remember that hospice surveys can, if there are more than one surveyor, can include other disciplines. And we certainly have seen nurse practitioners as well as pharmacists as social workers, but really pharmacists in terms of IPU. So providing a portion of that IPU survey. So it's going to be interesting to see, how this is met, but no doubt there is a separate focus related to those hospices that do have IPUs.
Okay, next one. And just real briefly to look at, they actually now are more specific. If there is an inpatient unit, then they're like, you can see where 1 to 4 patients, 5 to 16, they want a certain amount of inpatient sample record reviews. This again is something new. There was never a particular or very specific of how many to do when you had an inpatient unit. And then how would they pick them? For reason for inpatient care, GIP or respite, length of stay, and then just like with any other visits, presence of wounds or ostomies, other high intensity or complex care such as infusions, or someone that maybe is getting a lot of pain medication, things like that. They're going to highlight on some of those type of visits in the inpatient unit. Okay. This is a condition of participation, one of the associate quality of care COPs. This has to do with the skilled nursing facility, any type of nursing facility. You're going to see when you look at the new survey process that they're really looking at the collaboration of care, communication, and what you oftentimes see in this type setting with hospice patients is you're not seeing they're not delineating well who does what. And where you oftentimes will see issues is particularly with like wound care, things like that, where in the hospice plan of care, it will say the facility is doing the wound care. Well, the hospice is actually in charge of the plan of care, so it's very important that the hospice realizes that they have to oversee that wound care. They have to make sure that weekly they're getting the measurements. If possible, they need to actually visualize it at least weekly and make that part of their documentation. You can't just be passed to where the facility is doing that. And also what they're going to look at when they go into a facility is related to the chart. Does it have all the required information? If the nurse at the nursing home, they have certain requirements that they need from the hospice. And what is your practice related to documentation? Some hospices will say, well, we're going to bring back the computerized note the next visit, which obviously is not always a good practice because it doesn't get into the chart. Also, the survey is going to look at, do you have updates? Do you have a plan of care in there? Do you have updates to the plan of care, such as the IDG note? And is the hospice participating in, say, the facility conferences for that patient? The other thing that they're looking more at too is how are you educating the facility staff? Are you training them in the hospice philosophy of care? Are you offering annual in-services? Sometimes that's very challenging based on their time, the time they are allotted for you. But a lot of times you can do like a webinar like this and offer that to them, and then they can share it at a staff meeting for as a suggestion. Okay. And this is the phase 2, just talking about QAPI. It really has not changed in regards to the QAPI program. They're just going to be looking at, are you focusing on the high risk, high volume, problem prone areas? Who's responsible? Do you have process improvement projects working on those and different things like that? And if you have all the required elements as part of your QAPI program. So I don't see, but you're going to see where on the new survey process, where they're going to be asking more specific questions related to what's the data that you're tracking. Are you tracking some hospice specific or palliative care specific data? And the other thing would be your governing board related to QAPI. How involved is your governing board? Well, they have to be extremely involved with the QAPI program, and you're going to need to show that to the surveyor when the surveyor is there. These are just the phase 2, the other required COPs related to the quality of care. You can see where all those are talking about the core services, nursing services, furnishing non-core services, and the therapy, all of that related to the COPs. The one I did want to mention just briefly is about volunteers. Volunteers are, it's going to become more in the focus now because of the fact that the waiver is going to be, over. So now you're going to have to concentrate then on the assessing for the 5% and looking at the cost savings and all of that again. And you're going to see where in the new survey process, the different questions that they're going to be looking, talking to the volunteer coordinator, talking to the volunteers, and make part more evidence of that the utilization of the volunteers, or that they're at least trying to get the recruitment and retainment for the volunteers. And the last few slides are just, I'm going to real briefly go through these very quickly. I'm not going to go word for word because we're running out of time. I could probably continue to talk, and you've probably had enough. But survey readiness, you're going to have copies of these. These are just something to think about. The one thing, get a binder, always, get a binder, constantly updating it, and look, if you're using an accrediting body, look at what they require pre-survey, or when the surveyor gets there, and have that all ready to go. And then as soon as you know that surveyor is on site or coming to your organization, that's when you start printing out your list. Have your census ready, have your discharge records ready. I mean, your discharge list ready, different things like that. Have it all ready to go. It's so much easier for a surveyor if things are already in a book, such that they may require certain policies, procedures, all of that. And then you can just kind of scroll through the last couple here, and just and it just gives you a list here of the different things that you want to have available. One thing just to consider, and then I will turn it back over to Kim, is the fact that make sure when the surveyor gets there, get working on the EMR access. There's many times a surveyor will sit there for hours trying to get electronic medical record access. So it's very important to get that right away. So in case it does take a little bit of time. And then the last one is the final reminders. Is you can read those, but really survey readiness should be an ongoing agency-wide effort. Now with this new hospice, these new hospice processes, they seem a bit tedious when you read them, but actually read them and they really spell out, hopefully, what the surveyor is going to be looking for. And hopefully we're going to see more of consistency across the board, which I think has lacked a little bit in the hospice world. So, but take a look at those, and those are going to really help you prepare for your survey.
As we finish up here, I do want to point out that we do, our survey readiness team, our compliance and regulatory team does have another complimentary webinar next week on overall survey readiness, and many of these survey reminders in terms of how the documents and processes you want to be able to demonstrate during survey will also be included in that our program for both home health and hospice. And I just, as we conclude our presentation, I do want to say that I'm proud of our SimiTree survey readiness and regulatory team, which is comprised of current, former, and certified surveyors like Lynn, and accreditation certified consultants. And we hope you found this presentation helpful. And our team certainly looks forward to continuing to support your all hospice providers in your ongoing survey readiness efforts. And with that, I'm going to turn it back over to Missy to finalize, to take us out.
Thanks, Kim. Thank you guys for a great presentation. We did have a couple of questions, Kim, that I think, I don't know if you want to run through real quick or if we want to email everybody back out.
I think that we can respond. These require more than what we can say on this email, but I mean, on this presentation, but we'll be happy to send them out to
Excellent.
to everyone. And that way we have more detail.
Exactly. So we will get that in there. Rebecca, I see you raised your hand. If you don't mind throwing it in your question in the chat. How do you get notifications and trainings ongoing? If you follow our LinkedIn or Facebook page, all of our trainings and webinars are posted there on a regular basis. Rebecca, if you did have a question, if you want to put that into the chat or into the Q&A, I'll look for it there. I don't have the capability of taking you off of mute. But in the meantime, thank you all for joining. A copy of this webinar will be emailed out. Usually it takes about 72 hours, but you'll get a copy of the recorded webinar and the handout. If you do have any questions though, Kim and Lynn's information is here on the screen. Please don't hesitate to reach out with questions. We're always available to assist you in whatever way possible. With that, I will say thank you very much. And please, we look forward to seeing you next week.
Thank you.
Thank you.
Thanks for joining us.